So we have Dr. Amrita. She will be speaking on neovascular membrane causing blockage of earlier functioning trabeculectomy system.
Good evening, everyone. So my paper is on a descriptive case study of a neovascular membrane causing blockage of earlier functioning trabeculectomy stoma. So neovascular glaucoma, as we all know, is an inflammatory glaucoma characterized by neovascularization of the anterior segment secondary to retinal ischemia. It is a fulminant disease, requires urgent intervention. Surgical intervention in the form of trabeculectomy with mitomycin C or implantation of glaucoma drainage devices may be required for the control of IOP. So, a 63-year-old male patient presented with the complaints of left eye diminution of vision since 7 months. It was gradual in onset, painless and progressive. He gave a history of undergoing cataract surgery in his left eye 7 months ago. The patient was on nil topical medications and was a known diabetic. Coming to the examination part, BCVA for both eye in logma was 0.2. Left eye showed a IOP spike, a high IOP of 38 mmHg at presentation. Anterior segment in left eye showed fine NVI or neovascularization of iris. On gonioscopy, open angles were seen with neovascularization in the nasal angle. The optic disc findings were healthy in both the eyes, vertical CDR being 0.04:1. The fundus findings in the right eye was of non-proliferative diabetic retinopathy changes. Left eye showed vitreous hemorrhage inferiorly and proliferative diabetic retinopathy changes. So my diagnosis in the right eye was NPDR with age-related cataract. In left eye, it was a pseudophakic eye with PDR and neovascular glaucoma. Management 3 sitting of pan-retinal photocoagulation was done in both the eyes. Left eye was started on topical timolol and brimonidine fixed-dose combination, eye drop dorzolamide and oral acetazolamide tablets. Left eye also underwent intravitreal anti-VEGF injection of ranibizumab, followed by trabeculectomy with mitomycin C under local anesthesia. And it achieved a IOP of 12 mmHg with good diffuse filtering bleb. There was resolution of NVI, the rubeosis, 6 weeks post-operatively. The patient was followed up 3 monthly and was found to be stable. Now this is a slit lamp photo. The first photo in inferior gaze was post-operative 4 week and showed a good superior diffusing bleb. And the second photo showed a resolution of NVI. 9 months after the surgery, the patient presented with the complaints of heaviness in left eye. There was NVI noted. IOP was again noted to be 26 mmHg. On gonioscopy, there was a fine lacy membrane of neovessels covering the trap stoma noted. Immediately, fill-in PRP was done in the left eye, followed by anti-VEGF injection. Left eye was taken up for bleb needling in the operating room. Entry was made in the AC beneath the scleral flap with a 30 cc needle to disrupt the neovascular membrane. On 4 weeks follow-up post-needling, the membrane showed complete resolution and there was revival of the filtering bleb. IOP then noted was 10 mmHg. So the first is the gonioscopy photo before needling. There were fine neovessels covering the trap stoma seen. The second photo shows resolution of the neovascular membrane after anti-VEGF injection, fill-in PRP and bleb needling. So neovascular glaucoma is a high-risk factor for failure of trabeculectomies. Trabeculectomy failure in these eyes is traditionally managed with the implantation of GDDs. GDDs is a good treatment option, however, carries risk of tube and plate related complications. Therefore, we propose the maximum attempts to be directed towards the functioning of the primary trabeculectomy, so secondary procedures can be avoided. So, neovascular glaucoma that undergoes trabeculectomy need close follow-up to monitor the primary retinal condition as well as the filtration of the bleb. And timely control of ischemia and VGAF load can help in maintaining the IOP control in these eyes. Thank you.
What are the common causes of neovascularization of the angle of the anterior chamber, ma'am?
Diabetes, post-occlusive disorders such as CRVO.
Other than these two?
Then can be a masquerade syndrome. There can be any tumor that is causing malignant tumor that can cause NVI. Then can be even old retinal detachment, very old retinal detachment can also present with NVI. So.
Can it be there post-traumatic also? You never know.
Yes, sir. Yes, sir. Sorry, sir. The time.
Between the anti-VEGF and the trabeculectomy.
Sir, in this case, we had waited for a period of 2 weeks.
2 weeks.
Yes, sir.
Okay.
Thank you. Thank you.
Thank you, Dr.
Thank you,
Amrita.